coming to the last session of the event. I request Dr. Seema Kashyap to start with her presentation.
Good afternoon, everybody. I'll be talking on pediatric orbital lesions. Now, pediatric orbital tumors are rare. The differential diagnosis is very challenging, and because most of them are just small, malignant, small round blue cell tumors, and so you need a wide immunohistochemistry panel for a confirmatory diagnosis. And the core biopsies are so tiny. Again, the IHC is very difficult. It's very challenging, and genetic analysis also. So this was a 7-year-old child with a right orbital lesion since birth, which was gradually increasing in size. So CT scan shows a large mass, as you can see, with some cystic and solid areas, and an ectopic tooth within it. No eyeball was seen, and a lead-sparing orbital exentration was done, and the tumor was excised. And as you can see, this is the fleshy tumor which we got. And coming on to histopathology, you can see that there's a stratified squamous epithelium, and numerous hair follicles were seen representing the ectodermal layer. There was this cartilage, lamellar bone, bone marrow with bone marrow elements, intestinal epithelial lining along representing structures from the endoderm. So this was a mature orbital teratoma with an ectopic tooth in a primary anophthalmic socket, which is very rare entity. Another child, 6-year-old, who had proptosis of the left eye since 2.5 years, which is gradually progressing in size. As you can see, in September, this was the proptosis, and it progressed to this size within 6 months. So the CT picture, you can see that there's a large extracorneal mass in the left supratemporal orbit. So at this point, the clinicians had a differential diagnosis of an abscess, but the points against were no fever, schwannoma with cystic degeneration, solitary fibrous tumor. So when the mass came to us, these are the sections that we got. This was a tumor where there were multiple elements. This is the glandular element, that is gland-like arrangement was seen with tumor cells, hyperchromatic nuclei. And also we had the squamoid differentiation in a fibrotic stroma, along with mucin secreting cells, and AB pass was positive for mucin. So this was a mucoepidermoid carcinoma, which is very rare in the lacrimal gland, and even so rare in the pediatric age group. Usually they are cystic, and in this particular case, the long duration of symptoms, age of presentation, radiological picture was actually misleading, which was a surprise for the clinician. This was a 7-year-old child with proptosis, and on the CT also you can see the large mass filling up this orbit. In addition, the child had swelling of the right foot and right inguinal lymph node swelling. So we decided to do FNAC, and FNAC you can see in the papinicular stain, the PAP stain. It was a malignant round cell tumor. Same is seen in the MGG or May-Grindwald Giemsa stain. They are irregular hyperchromatic nuclei. We had some material left, so we prepared a cell block. Again, it showed a round cell tumor with areas of necrosis. And we resorted to immunohistochemistry. Desmin, NSC, MPO, all were negative, ruling out a rhabdomyosarcoma, granulocytic sarcoma. But IHC for MYC2 was positive. So MYC2 is positive in PNETs. So this mass was excised, the entire mass, and in the biopsy, in the sections also we saw a round cell tumor with numerous mitotic figures. Again, MYC2 was positive and PAS was negative. So this was a primary primitive neuroectodermal tumor of the right foot with metastasis to the left orbit. Another child with proptosis, and you can see the proptosis is so huge, it is just pushing down the eyeball. And in the histopathology, it was a malignant round cell tumor. So we resorted to PAS stain. PAS was positive in these cells, along with MYC2. Now in such a case, when MYC2 is positive in PNET, and when PAS is also positive, it's a Ewing sarcoma, the same group of tumors, but this was Ewing's. And on systemic examination, this patient had a mass in the pelvis. So this was basically an Ewing sarcoma pelvis which was metastatic to the orbit. This was an 8 months old child, gradually progressive proptosis of the left eye since 1 month with decreased extraocular movements. Congestion was there, tender to touch. And on radiological examination, you can see a well-defined round to oval hyperdense lesion in the intracorneal and the corneal region of the left orbit. And on non-contrast CT, the diagnosis was query orbital hemangioma, query RMS. Again on USG, the diagnosis was query hemangioma. This was the mass which we got, a fleshy looking mass. And sections showed a round cell tumor again, this time again. It was a monomorphic round cell tumor with mitotic figures. There were some areas which showed vacuolated cells. In the lower picture, you can see numerous mitotic figures, vacuolated cells. So this was definitely a malignant tumor. And so differential diagnosis for us, the pathologists, now this time was an atypical Ewing, myeloid sarcoma or sarcoma with BCOR genetic alterations, which is a very new entity. So we resorted to immunohistochemistry. INI1 was positive, diffusely positive, SAT-B2 was positive, and BCOR was also diffusely positive. So we resorted to genetic analysis. FISH was done, fluorescent in situ hybridization was done, which showed the BCOR CCNB3 fusion. So this confirmed our diagnosis of sarcoma with BCOR genetic alterations. There are many alterations which can be seen, BCOR CCNB3 sarcoma or BCOR ITD sarcoma, which is more common, but in our case it was BCOR CCNB3 sarcoma, which shows round cell tumor. These are very rare aggressive tumors with a poor prognosis, hence an early diagnosis is required. An excision of this tumor has a good remission rate. Metastasis commonly to the lung. 5-year survival is about 72 to 80%, and this is the picture of the patient after chemotherapy. The patient responded very well to chemotherapy. So these are rare orbital tumors which should be kept in mind in the differential diagnosis, both for the pathologists as well as for the clinicians. Thank you.
Really been come to know so many new findings. We'll go from the beginning.
Yeah.
Any questions from the audience?
How often do you use IHC as a routine tool?
Routinely we use IHC. We have to resort to IHC. Yes, all malignant.
Is there a first panel to do, and then look at the clonality and then look at
No. We first do see the morphology, the history, everything into account, and then accordingly decide whether it's a lymphoma-like thing or it's a RB-like thing, or so accordingly we decide the panel. We can't do everything together. So according to the morphology, we resort to the immunohistochemistry panel.
Okay, then we'll go to the next speaker. Multimodal imaging for ocular surface tumors, Dr. Puneet Jain.
Thank you so much, and thank you, the LOC, for making me a part of this session. So let's begin with the presentation. So before we move on, one should remember that if you have access to fancy things, you should not leave the basic things behind. So a detailed slit lamp examination and vital staining in tumors takes precedence over any imaging tool. And one should not jump to these imaging tools, which I'm going to talk about subsequently. So ocular oncology has come a long way in last 3 decades. There has been a huge expansion in spectrum of ocular surface diseases, tumors, and our understanding of it. Alongside, there has been an evolution in anterior segment imaging as well. That could be a good slit lamp photograph or an ASOCT, and subsequently other investigations. The non-invasive nature of these imaging techniques has led to their acceptance on a very large scale, and also the increased availability. So there was a time when an anterior segment OCT would be available at select places, if I talk about Delhi, and now almost every setup would have one basic OCT, and if you attach an anterior segment attachment to a posterior OCT, you can get a good ASOCT as well. So there's a huge spectrum of ocular surface tumors, and many of these can be differentiated amongst themselves using these imaging techniques. So what is the implication of using? Is it just diagnostic? No. So obviously they are a diagnostic aid, that is why they are used, but they also decrease the reliance of an ocular oncologist on excision or incision biopsy. So prior, whatever was clinically indeterminate was probably biopsied, but now having an understanding of these imaging tools allows us to have a little more freedom wherein we can observe for serial changes 6 weekly, 3 monthly before we decide on taking any surgical decision, especially if our pointer is towards a benign lesion. Also, they help in therapeutic decision making if we are planning to manage the case non-surgically, and also at the same time monitor the therapeutic response. That said, histopathological examination still continues to be the gold standard of care for ocular surface tumors, and imaging are just the adjuncts to arriving at a tumor. So that should be very clear. The current armamentarium, there are 4 such investigations. One is the ASOCT, then the ultrasound biomicroscopy. IVCM is not commonly used, and recently OCTA has been used, but there are no characteristic feature of OCTA which would help one to diagnose tumors. So this is still in infancy, but I'm sure in times to come this will also be a handy tool. So anti-segment OCT has evolved itself from a time domain OCT to a spectral domain OCT. So when I was in my JRship, we mostly had time domain OCTs, and now everywhere we have much better generations of OCT. So what did this do? This led to better resolution of images, which was very important for imaging surface tumors. Now even with the newer resolution OCTs, with newer generation OCTs, the resolution is even better. So just to give you perspective, the axial resolution of a time domain OCT is just 18 microns, whereas that of an ultra high resolution OCT is 5 microns. That makes a lot of difference. And also that these are non-contact procedures compared to the others, so they are very patient friendly. Coming to the most common ocular surface tumor that we come across, ocular surface cumulus neoplasia. So Carol Karp and group have described the classical high resolution OCT findings of an OSSN. So this is something that is a common knowledge when it comes to the ocular oncology circle. So you see when you take a section through the lesion, you see that the corneal epithelium abrupt transition to an hypertrophic, to a thickened hyper-reflective epithelium. This is the characteristic feature. Sometimes you can see this lucid zone between the tumor and, as you can see in this patient, between the sclera. That is also a important finding. So these preoperative changes beautifully correlate with the histopathological findings if you were to biopsy the patient or treat the patient surgically. They also help differentiate between the various benign masquerades. Obviously this is a characteristic case, but in clinically indeterminate cases that can be very useful. They are very handy in managing response when treated with topical immuno or chemotherapy. With treatment there is reduction in epithelial thickness as well as the hyperreflectivity. So let's take a case. So this case was referred as query corneal plaque, query OSSN to my OPD. I did a rose Bengal stain, it was apparently negative. The limbus and conjunctiva was clear. So I would not start this patient on interferon therapy. There is enough doubt in my mind what to do. So I did an ASOCT. The ASOCT was also kind of unequivocal, though there was some increased thickness of the epithelium, but there was no abrupt transition as such. So I decided to have a close observation on this case, and I called the patient at 6 weeks. Now at 6 weeks you see there's a beautifully delineated lesion with corkscrew vessels and intrinsic vascularity. I did an OCT for this patient. Now you see all the characteristic findings, but you see that the epithelium is not that hyperreflective, probably because the lesion is very, very thin, right? So this is how these investigations help us. So the patient was started on topical immunotherapy as per the standard protocol, and this is how the patient was at 1 month of age, 1 month post-treatment. So you see that the epithelium is back to normal, and the hyperreflectivity, whatever subtle hyperreflectivity was there, is also gone. So this is how the patient presented. This is how the patient was at the first follow-up, that is 6 weeks, and this is how the patient was post-therapy. So these images. So if this was in an era of absent ASOCT, probably I would have called the patient after 3 months or 6 months and not that close interval, because I would not be able to determine the change in the lesion. So what is the point of calling the patient at such short intervals? So this is how the resolution was on ASOCT. So what are the limitations of ASOCT? Okay, I'm running out of time. All right. So leukoplakic OSSN, there will be shadowing, a thick pigmented OSSN, there will be shadowing. So just to give you perspective, if a lesion is more than 465 microns thick, you will have shadowing on ASOCT. This is how shadowing looks. leukoplakia OS, and you really cannot see behind the lesion whether there is an intraocular invasion or not. So you would require further imaging in this, wherein the role of UBM comes into play. So UBM can be 50 megahertz or 20 megahertz. The 50 megahertz one has a better resolution of lesions, but less penetration, and the other one has obviously deeper penetration. So the role of UBM is in shadowing. The role of UBM is also very important in recurrent OSSN, where an ASOCT will not give you a good image. So accurate depth assessment in such lesions has to be done with the help of a UBM. So there are characteristic UBM findings. We'll not go into the details. If there is intraocular invasion, then what should you look for? So anterior chamber blunting would be the first sign. There could be frank angle infiltration. There could be increase in the thickness of the ciliary body or the entire uvea in that region. There could be gross intraocular invasion. Limitations of UBM is obviously that's a lower resolution tool. So you would not do a UBM in a thin tumor. An ASOCT does better when there is no shadowing. It is a contact procedure. Whoever is doing the UBM requires a lot of training. The patient has to be under a water bath for some time, so patient cooperation can be poor. And UM is not that frequently available. Even in Delhi, there are very few setups, government and private included, which have UBM. So this is one article. If there is anybody young who wants to pursue oncology or is doing oncology, this is a good article to familiarize yourself with how a UBM finding, how a novel UBM is. This is how angle blunting looks, just to give you some perspective. This is how an angle blunting looks on a UBM. So coming to the last bit, so this lesion was referred to me for conjunctival melanoma based on this dilated blood vessel, which was being called as a feeder vessel, which is controversial. But if you see closely, there are cysts in this lesion. So these presence of these intralesional cysts is a giveaway for nevus, and if you have ASOCT, you can take a image through the lesion, and you can document these, and you can send the patient home for a 6-monthly follow-up. And if the patient is cosmetic inclined, obviously in this case, it's a large nevus, you can remove it. So just wrapping up, couple of more slides. So an HROCT would also help differentiate between a melanoma and a pigmented OSSN and vice versa. So an OSSN versus a apigmented amelanotic melanoma. So remember that these are not epithelial lesions, so the subepithelial tissue will be hyperreflective in these cases, and most of these melanomas tend to be very thick, so you would need a UBM to rule out intraocular invasion. ASOCT will fall flat when it comes to diagnosing a melanoma. Just a bit about lymphoma. So a very typical picture of how a lymphoma would look in ASOCT if you were to image it. Most of the lymphomas are large when they present to us and would require imaging in the form of CT or MRI. But if you do come across a lesion that you cannot differentiate between a benign reactive lymphoid hyperplasia and a lymphoma, the epithelium is normal in both, but the characteristic feature of BRLH is high variable hyperreflectivity. That is because of the infiltrates that you see, the pattern of infiltrates that you see on biopsy. So this is an important point that would help you distinguish between the two as well. Ray, thank you so much.
Thank you, Dr. Puneet. That was a good insight into the use of ASOCT. Actually, we all had observed that ASOCT is much useful and much practical than UBM. Most of us, actually some of us get trained to do it, but at the end we keep it aside and use the ASOCT. Right. Okay, any inputs on the use of ASOCT in limbal dermoids, the depth, the grades, and when do you go in and, you know?
See, limbal dermoid, if the limbal dermoid is, so we're talking about the corneal part, right?
Yes.
So you have to take a decision whether you can operate yourself or you do need a patch graft or a help of a cornea specialist or your colleague. You usually see a lot of shadowing on dermoids as well. So it is very difficult. So if you are not sure what is the exact depth of the lesion, you might as well keep.
Because it's a child, it's going to -9 diopters of astigmatism,
Right.
then we have to go in.
So it does help, but see, when these lesions, if the child is presenting early, like let's say within 5 years of age, and if you can get a good ASOCT image, it will definitely help you. But if the child is presenting in adolescence, there are already a lot of changes that have happened over the lesion. So there might be some calcification, all those things. In those cases, your ASOCT will not work. So UBM would still be my preferred choice if it is a larger dermoid causing that much astigmatism.
Yeah, and I had another situation where we removed it. There is a large pseudopterygium now. So then it is looking little doubtful after a few months, like whether ASOCT will give me an insight into
No.
what's
Fibrosis, once you have operated and then you are trying to image something, it will just show fibrosis. Fibrosis has no typical features on ASOCT. So it will just look like a thickened epithelium. That is what the problem is in recurrent tumors which are not operated. So you don't have a biopsy report. and the patient comes back to you, and the
Whether ASOCT will help us in like knowing, because it's showing some surface changes now, whether,
see,
should I
if you're sure of the diagnosis it's a dermoid, then you really don't need to worry about anything else. You just have to make the ocular surface right. There will be a big Dellen if you remove, so that
Okay.
all these things you have to
The
anticipate.
child is doing fine, it has come down from -9 to -3 now, I think.
So when did you operate? At what age did you operate the child?
At 2 years of age.
Okay. So there's another fun fact. The thing that if you operate the child beyond 10, the astigmatism will not go. Even if you remove the lesion, the astigmatism will not go. So the astigmatism will respond if you operate the child early, but imaging techniques in these cases
Yeah.
would not be that handy.
Okay, thank you.
Yes, sir, please.
Thank you.
Your experience on situations where it's been biopsy, on have you re-reviewed your radiology findings to see, especially in pigmented lesions and OSS? Has there been a difference once you have cases of pathology?
So
Re-reviewed your radiological
no. So sir, it's like that. So if I am biopsying a lesion, the current rule in oncology is to do excision biopsy wherever possible. That is the first point. So you were talking about incision biopsy. Incision biopsy, only scenario would be a large melanotic lesion in which I cannot see a posterior border, so I am biopsying it with the diagnosis of melanoma in mind. In such cases, I would not be even tempted to correlate my histopathology with my imaging techniques. My focus would be on metastasis. So are you getting my point? So there has not been a situation yet where I have to go back to my imaging. So there has not been a situation. See, I have about 7 years of experience. I'm still young in oncology, but I haven't had the need to go to an ASOCT or a UVM back to relate it with my histopathology. It can be other way around. I mean, so I am having a purple patch. I haven't yet come across a tumor like that. Yeah, it's an absolutely valid question.
I think this is a good food for thought. Like we can go back and do a study on this. Hello, hello.
Yeah, so surface tumors tend to be simple. Right. Yes, ma'am. I am not aware of any protocol for frozen sections for ocular surface tumors per se, but this no-touch technique, which as described by Shield, says that if you have an excisable lesion, you take a 4 mm clinically clear margin, and then you do edge cryotherapy to the tumor-free end. That makes it a 8 mm clinically clear margin. So, role of frozen sections in ocular surface tumors, not sure.
Okay, now we'll go on to the talk by Dr. Vishal Sharma on OSS in and out.
Thank you, Puneet, for making my job little easy. I have no financial interest, and these are my associates. And I acknowledge my mentors. So OSSN refers to a spectrum of epithelial tumors affecting the ocular surface, including the conjunctiva and cornea, causing significant ocular morbidity and potential vision loss. Classically classified into conjunctival intraepithelial neoplasia, corneal intraepithelial neoplasia, and squamous cell carcinomas. Is generally seen in person exposed to the risk factors like UV radiation exposure, HPV, HIV/AIDS, immunocompromised states, previous history of radiation therapy, or genetic predisposition. Diagnosis is essentially done by clinical examination on slit lamp with its classical presentation, like leukoplakia, feeder vessels, intrinsic vascularity, keratinization may or may not be seen. Like in this case, you can see intrinsic vascularity nicely seen over the corneal lesion over here. This is a high MAC picture of surface keratin. It can be a pigmented OSSN or a diffuse corneal OSSN in a case of xeroderma pigmentosa treated with topical interferon. Nodular OSSN with rose Bengal skin positivity is seen in this case, or it can at times be closely mimicking the of scleritis. UBM and AIOCMT3, as talked by Dr. Puneet, may help in the diagnosis part. Impression cytology and incisional or excisional biopsy gives histopathological confirmation for the OSSN. So coming to the management part, couple of years back, me and Dr. Puneet had debated upon whether to choose a knife over a drop. Certainly, we both were correct with our set of points, which varied depending upon the case scenarios. While surgical excision is the choice in large and invasive lesions, it provides a histopathological confirmation as well. Whereas topical chemotherapy is preferred choice with advent of cornea-friendly medications, and usually these have almost complete resolution in almost all cases. Being less corneal epitheliotoxic, interferon is my first choice of drug, while mitomycin C and 5-FU is a reserved bouncers for me for refractory cases. These are few results, like in this case with a leukoplakic lesion at limbus with corneal involvement seen inferiorly. After 3 cycles of interferon, this was the result. Again, corneal limbal lesion in this case. Post 2 cycles, the result is quite good. In this extensive lesion as well, it worked well with, this is a picture after 4 cycles of interferon. So, if at all we plan to have surgical excision, there are certain key points in surgical management that we need to keep in our mind. Delineate extent of lesion with rose Bengal staining prior to surgery. Take wide excision, wide clinically free margin of around 3 to 4 millimeter, and use the no touch technique for the surgery. Corneal component is treated with alcohol epithelectomy. Superficial sclerectomy may be required in selected cases with scleral fixity. Cryotherapy is used as an adjunct additionally for any microscopic residual left over at the conjunctival margin, resected margin, or at the scleral bed. How do we send sample to histopathology? Excised tissue has natural tendency to curl in. Hence, it becomes difficult for pathologists to comment upon the margin and as well as at the base of the lesion. Therefore, sample is mounted over a Whatman filter paper with a representative diagram and orientation of tissue as in situ, and is sent in 10% formalin to the lab. So these are few examples of few cases which were surgically managed. If there is a scleral or intraocular invasion, what would we do? If it is scleral or just a superficial invasion or so, we can plan for plaque brachytherapy. These are few cases which had scleral positivity, the base positivity of the excised lesion, which were subjected for plaque brachytherapy later. And these patients are tumor free after 1 year of follow-up. In OSSN with intraocular invasion, we, like in this case, 22-year-old female with xeroderma pigmentosum, enucleation was done, followed by ocular processes. Whereas, in this case of 63-year-old male with recurrent medial canthal mass with orbital extension locally, the lesion was excised from the local region, followed by external beam therapy was given. With extensive orbital involvement, as in this case of 58-year-old male, was treated with exenteration and orbital processes was given. So the prognosis depends upon the size of the tumor, its location, histological grade, and its response to the treatment. Prevention can be done by limiting UV protection, UV exposure, HPV vaccination, avoiding immunosuppression, and having regular eye examinations routinely. Thank you.
Thank you, Dr. Vishal. Actually, we should have a high index of suspicion about the surface findings. Sir, I have a question for you, sir. I had a 45-year-old female who came to me with some redness in the eye, and it was an extralimbal lesion. It looked just like a pincushion, nothing more than that. But when I saw on the slit lamp, the surface looked very doubtful for me. She was not a known retroviral patient. But I asked her and I sent her for the investigation. Somehow the surface looked very doubtful. She turned out to be positive, retropositive. Then I took up the patient for excision. It turned out to be a OSSN. So in these cases, I think that will give one clue, no sir, like just to give them. Screening, but I don't know, somewhere it just told me the surface looks very, because it's first time I saw extra limbal, like all these cases were limbal. So this patient also has a lesion now in the nasal limbus. I am just closely following that lesion because it just looks like a now early pterygium or pincushion. The surface looks fine. I think I need to follow up. And this patient is quite poor, sir, so I gave her MMC post excision. So the patient is intolerant to, she comes back every time with redness. So 5FU has a better chances in that patient. Profile. So post-excision there is no rule. I don't have to, because the margins were clear anyway, so thank you.
So our next speaker is Dr. Shalin Shah.
Okay, so I have few cases where I had a benign lesion and a malignant lesion. I mean, two separate cases who presented in a very similar way. So all of I have no financial interest. So we directly go to our cases. So first, we had two young male patients who came to us. History similar, red eye since 3 to 4 months, a painless mass, progressively growing, no history of bleeding. So these were the two patients, case 1 and case 2. So case 1, we see that there's a large white lesion. Otherwise, there's no redness. In case 2, there's a large congested lesion, and the entire ocular surface is congested with hyperkeratinized area. So the case 1, who had a left eye mass, examination showed that, examination of the other eye showed congestion in the right eye as well. So this was the left eye mass, fungating mass growing on the temporal side, abduction deficit present. And in the right eye also there was congestion and a flat mass growing on the temporal limbus less than 1 clock hour in size. And as we can see from the face of the patient, it was a patient of xeroderma pigmentosa. Whereas our second patient, a unilateral mass growing in the right nasal side, and it was a blind eye. He had a history of trauma, loss of vision some 15 years back, and a query history of a retinal surgery, no definite records, and a USG showed disorganized contents, probably treated as an RD, a failed RD surgery was done. So this was a conundrum for me, that how to treat both the masses. The first case was a definite OSSN in a xeroderma pigmentosa case, whereas the second one very much looked like an OSSN case. So we did an impression cytology. First one showed definite neoplastic cells. The other patient showed desquamated atypical cells and inflammatory cells, but it was not conclusive. So we went ahead, first case, we gave them neoadjuvant chemo for reduction since MRI showed invasion of the lateral rectus insertion. And in the second case, we went ahead with an excision biopsy of whatever visible tumor was there. And when we excised, we had an exposed scleral buccal underneath, which was the reason for such a presentation. And the histopathology came out to be a pyogenic granuloma. And this was the explanted scleral buccal in the same sitting after excision. And the patient was managed conservatively with topical steroids. And after 1 month, the entire congestion, hyperkeratinization, everything disappeared. The first patient is still undergoing his neoadjuvant chemo, so I don't have his follow-up right now. So this was our first conundrum, an OSSN versus a pyogenic granuloma due to an exposed buccal, both presenting in a very similar way. The one difference that sentinel vessels I should have spotted in case 2 if it was an OSSN, but it was a diffusely congested mass, diffusely congested ocular surface, so there were no visible vessels as such, dilated vessels. Now cases 3 and 4, both were elderly patients, 1 male, 1 female, complaining of unilateral watering with redness over 6 months, and there was some whitish discoloration along the lid margin. So they were first seen by a general practitioner who told them it was vitiligo. Then they were referred to a comprehensive ophthal who noticed a white mass in the fornix. And so these were the 2 patients. The first patient was a male patient. Only in the left eye, there was discoloration of the lower lid margin and some involvement along the upper lid punctum as well. And the other patient, we can see there is a large mass with an ectropion. So for third case, the male patient had no ectropion, lag of thalamus. The tear film was normal. And the fourth patient had severe ectropion and a history of cataract surgery. There was severe dryness and frequent touching of the eyes. So these were our cases. So we went ahead with impression cytology. It was inconclusive in both the patients. So we went ahead with an incision biopsy. The first case, it showed carcinoma in situ, squamous cell carcinoma. Whereas the second case, there were no atypical cells. It was just hyperkeratinization. Now, what was my conundrum in the case 4? Here we can see with the green arrow, we can see some atypical blood vessels which we see on the surface of an OSSN. The rose Bengal stain did not really show any result, but the blood vessels were kind of a red flag for me, so I went ahead with a biopsy. And so we went ahead with a neoadjuvant topical chemotherapy for chemo reduction in the third case, since it was involving the lateral canthus, medial canthus, and the upper punctum. And the other case, we went ahead with a conservative management with lubricant, since the patient was not ready for a surgery. It was an 80-year-old female, actually. So at 1 month follow-up, the patient is undergoing treatment. The tumor load has decreased. There's a symblepharon developing in the inferior fornix. The patient doesn't want surgery right now, since he's also noticing a decrease in the tumor size. And the fourth patient who had exposure and keratinization, on conservative management, the size of the lesion has decreased and she is also on follow-up. So again, a conundrum between an OSSN and an exposure hyperkeratinized conjunctiva. And our last case was an elderly male, around 70 years. He had a left eye painful swelling since 6 months. Uncontrolled diabetic hypertensive. The fellow eye had good vision, 20/40 with moderate NPDR and CSME. Now the involved eye, left eye, he had lost vision 2 years back. He had some history of vitreoretinal surgery and silicone oil removal. The indication was not mentioned in his discharge card, but he said it was some retinal detachment. And after that, he had presented like this since 6 months, painful proptosis, and he was being treated as endophthalmitis, panophthalmitis, and a typical finding was a inverse hypopion or a hyperoleon. But since an SOR was already done, such a large inverse hypopyon should not have been seen. So we went ahead with a scan, and a CT orbit showed a unilateral mass in the orbit extending along the optic nerve. The other orbit was fine, and the CNS images were also fine, no CNS lesion. So we went ahead with an AC tap, which showed us atypical lymphocytes. Subsequent incisional biopsy from the orbit showed a non-Hodgkin's lymphoma, DLBCL type. Patient was HIV negative and no nodes, no CNS lesions. Unfortunately, the patient, after the second surgery, met with a road traffic accident, was admitted for around 15-20 days, and we lost the patient. So it's an unsolved mystery for us whether the primary surgery was because of an intraocular malignancy, primary vitreous lymphoma, which then spread to the orbit, or it was an orbital lymphoma which had an intraocular extension. So, thank you. Thank you, sir.
Very good collect. The scleral buckle.
Yes.
And we named it as a dragon in the eye.
Okay.
Because back in the days, like people in rural area, they are not aware of what being done on their eyes.
What is being done in their eye,
and
exactly.
After the vision is lost and it goes into thysis and all.
They
and it gets
forget
infected,
a follow-up that anything needs to be done. Exactly, it was a similar case, and the parents also had no idea what was done. They just had history of trauma, and some surgery was done. So we did not suspect a buckle, but yeah, it came out to be an exposed buckle which was causing everything. Thank you, sir.
Any questions, audiences, please?
Yes. Sir, I did not put them, but if you would like for academic interest, I should have put them. Sure, sir. Yes, thanks.
Good afternoon. I'll be speaking about minimally invasive orbital surgery. You must be wondering what is minimally invasive orbital surgery. Orbital surgery is always done with big incisions, and it's said that big surgeons do big incisions, but it's not always so. You have to kind of triage your incisions and the way you do surgery depending on the tumor. I'll be mainly talking about injectables and minimal access surgery itself. Injections, of course, we all now understand that they have come in a big way in management of orbital tumors, but we have to select out patients. It's not that every patient would need an injection, and in situations where lymphangioma or venolymphatic malformation is injected, we have to be sure of the diagnosis radiologically with MRI. Otherwise, we may inject in cystic lesions which may look like venolymphatic malformation, but not really so. We have had cases of adenoid cystic carcinoma, solitary fibrous tumors, etc., or even neurolemoma with cystic degeneration coming with multiple prior bleomycin injections done elsewhere. So that should not be the situation. But once you're sure that based on the history, like this patient had unilateral proptosis of the right eye with recurrent subconjunctival hemorrhage, all documented proptosis since childhood, with even an episode of a chocolate cyst acute hematoma. Now she wants cosmesis. She's just about a young adult now. But her tumor is all over the orbit, around the optic nerve, lacrimal gland, SRLPS complex, medial rectus, lateral rectus, intraconal, extraconal. There's no way we can safely debulk this lesion. So all we did, because it is intraconal, we trust picibanil more than bleomycin. You can see nice clearance of the intraconal space, completely extraconal space as well, and she got the cosmesis that she wanted. So this is a very simple clinical situation where injections can be given. Now, if a patient comes with an acute orbital hemorrhage because of a pre-existing venolymphatic malformation, then we aspirate it with or without radiological guidance. In an intraconal posterior lesion, radiological guidance is definitely important, but if the lesion is anterior, then you can do without it, and we would keep the needle right into the lesion. We don't disturb the needle at all once we aspirate, and then we change the syringe and inject bleomycin. So generally, earlier I would inject the equal amount of bleomycin. Now we reduced it to even half or 1/3, because you always get the second chance if the patient doesn't resolve. There are very rare reports of optic neuritis following bleomycin injection, so we don't want to have such complications. We can inject half of it. This was a patient where surgery was attempted elsewhere and it was abandoned because of heavy bleeding. And this patient, all that was needed was an injection of bleomycin. Again, acute bleeding, but in this patient the blood was clotted. It was not aspirable, so we had to do a small incision and evacuate the blood, and as we did that, we injected in the cavity, and this patient also resolved well. This is an anterior lymphangioma, again venolymphatic malformation, again treated with bleomycin. Now that works well. Now this is a case where there is a roof of the orbit missing, right? Of course, by history and the being a triradiate lesion in a child, peripheral blood smear being negative, so we have a presumptive clinical MRI diagnosis of it being eosinophilic granuloma, but then treatment of choice would be curettage, and here the dura is already involved. You can see that curettage would be very difficult, and even if you do it, you will be incomplete in curating it, and if you send it to a neurosurgeon, then obviously the child will suffer a lot of morbidity. So how do we do it? Of course, IHC is confirmatory for eosinophilic granuloma, but an ophthalmic oncopathologist who is well experienced in reading out would be able to give you a diagnosis under frozen section squash imprint cytology within 10 to 15 minutes. Suppose they are hesitant about the diagnosis, we can defer the injection. But since the pathologist is confident and we trust the pathologist, we can wait for about 10 minutes following this biopsy, which is done from the safe middle of the lesion, and inject right into the lesion under visualization. 3 months later, there is partial remodeling of the bone. 6 months later, there is complete remodeling of the bone and complete resolution of the tumor without any need for major surgery at all. So intraoperative diagnosis actually helps minimize the intervention. One more similar situation, exactly managed similarly. Now for orbital lymphoma, this is a patient with predominant conjunctival component, but not to miss this subtle lesion which is hugging the eye and going back very posterior between the SRLPS complex and the eyeball, lateral rectus and the eyeball, and the medial rectus and the eyeball, and superior oblique was infiltrated. Of course, if you challenge any surgeon, he would go ahead and remove it, but what are the consequences? And do you want to give radiation unnecessarily, right? So anterior component can be easily removed. We have pathology confirmation, and for the posterior component, we can inject rituximab. This patient was managed with 5 mg per ml, 6 injections of rituximab, 3-weekly interval, and there was no residual tumor. Now dermoid. Dermoid is a surgeon's delight. But what if a patient doesn't want surgery? This child has a lesion which is temporal. Now even with a lid crease incision, she is going to have a visible cut mark. There is no way we can go through this incision, hidden lid crease incision, and expose this lesion, which is actually adherent to the periorbita. This is one more young adult who has a similar lesion, but this is actually a dumbbell dermoid. I'll show you a video where how we do this sclerotherapy technique. Now we have to be sure on MRI that it has fluid content, not pultaceous content which is not aspirable. There's no point opening up to evacuate it, then it becomes very messy. So you can see this nice fluid content in this dermoid, which is aspirable. We mark the epicenter of the lesion, then we do it. Then we foam sodium tetradecyl sulfate. The needle is left in situ. The needle was inserted into syringe only for demonstration purposes. So needle is there in this thing, and then this is foaming, 1 to 5 foaming, and it is injected right into the lesion. And this is a different patient where you can see nice resolution of the dermoid following this injection. 1 to 3 injections are required. On an average, 2 injections are required for complete resolution. For surgery itself, for orbital biopsy, sometimes you have to make large incisions to get to the epicenter of the lesion. But then if you have image guided technique where you can use this technique, you can make much smaller incision, because now you know that you're right within the lesion when you do an incisional biopsy. Smaller incisions also are permissible when you use image guided technique. For the surgery itself, we rely more and more on transconjunctival approaches rather than open orbitotomy with lateral orbitotomy, bone cut, etc. This was a child with orbital teratoma, and diagnosis was quite obvious because you have this fully grown molar tooth right within the lesion. This was a tumor which was both on the medial as well as the lateral side of the optic nerve. Now this is the incision that we have made, lateral canthotomy, a small cantholysis, and an inferior phonacial incision. The lateral rectus and the inferior rectus are all tagged. That's the lateral cystic component with a very thin wall which could be dissected by blunt dissection. As we went medially, we could actually see the optic nerve which was not touched, left intact, and further medially we had this solid component which was easy to excise. This is the groove through which the optic nerve was passing. So we did not even have to dissect it from there, it got separated. This child resolved very well, his disc edema resolved, and all we need to now do is correct his esotropia, which probably is fairly easy. This was a young lady who wanted no scar on her face at all, but she wanted relief from this tumor that she had. Here we again did transconjunctival approach. She had a visual field defect as well with disc edema. That's the lateral canthotomy incision, an inferior cantholysis, and a transphonacial incision. Phonix is not like you don't go right into the phonix, but we have about 4 to 5 millimeter from the inferior tarsal border. That's where you make your incision. Ledge the inferior orbital margin with a large lid spatula. Dissect tissues. Our aim is to go to the inferior orbital margin right away without much of soft tissue dissection at all. Incision is made just a millimeter from the inferior orbital margin, not to injure the infraorbital nerve at all. Then you go on dissecting till you see one of the two endpoints, either the apex of the inferior orbital fissure or the infraorbital nerve, beyond which you don't want to disturb the periorbita because then you will have consequences. But then there are these blood vessels which are passing through the bone. These are perforating vessels. They need to be cauterized, otherwise they will continue to irritatingly bleed and obscure your visualization. That was the infraorbital nerve at the bottom below. Now we make a periorbital incision right in the quadrant where the tumor is present. Just 30 more seconds. Dissect the tumor to about 30 to 40%. Then we go little posterior, and when the tumor is 2/3 dissected, we bring in the cryoptope to assess its ballotability. And if the tumor is ballotable, we support it from the posterior aspect and gently wriggle the tumor out. There is no hurry at all here. And hemostasis is very important during surgery. As the tumor comes out, we will definitely visualize this posterior pedicle, vascular pedicle, which is the feeder blood vessel that needs to be cauterized. Sometimes the MRI specialist himself tells us that this is the vascular feeder vessel from where the tumor derives its blood supply. It's easy for us then. Now lateral canthotomy incision is closed, and inferior phonacial incisions are all vicryl absorbable sutures, and canthotomy sutures are also very small vicryl sutures. So patients do well, and this is the same patient after 2 weeks following surgery without any stigma of orbitotomy. Similar surgeries in adults as well, and this is a large tumor dissected. This is a neurilemoma. You can see the infraorbital nerve involved and the infraorbital nerve removed along with the tumor. That's the infraorbital nerve from which it was arising. So in conclusion, I would say that there are a lot of innovations in orbital surgery that we have advantage of, such as injections, even external beam radiation for many tumors, even benign tumors which are otherwise difficult to excise or may have functional implications, and of course minimal excess orbital surgery, which is very precise with much better outcomes than we used to have before. Thank you so much.
Hello, thank you sir for the beautiful insight. Sir, I have a question for you. In cases of orbital dermoid, so how much time duration you keep between the two injections, if at all?
At least 6 weeks.
At least 6 weeks.
Yes. And then re-image the patient and then see how much the lesion has collapsed. If it is partially collapsed, then we can actually go in and do the repeat injection. If it is nearly totally collapsed, then you don't do anything more.
And is it same that the amount of volume that we retrieve, that much only?
Absolutely right. But then the foam is the same. Suppose you aspirate 5 cc of contents of the dermoid, the foam, the final version of the foam is the same. But for foaming, I would take 1/5 of the volume. Suppose I aspirate 5 cc of the contents, I would use 1 cc of sodium tetradecyl sulfate and foam it. Foaming increases its volume. And also foam has surface tension, so it will go and coat the walls. Otherwise, if you inject a liquid within a lesion, then the liquid will by gravity settle at the bottom, right? It will not cover the entire wall. And the implications of injecting 5 cc of sodium tetrahedral sulfate without foaming is that there will be very severe inflammation. That's the reason why we foam it.
Thank you, sir. Any questions?
Yeah. Perilesional rituximab is something new, and we have had a very small series everywhere. Me and Dr. Hakan Demirci from Detroit, we are working together on this. He's also injecting, I'm also injecting. So we have a combined series of about 8 patients now. And all of them have done well. There is uniformly no patient without response. These are specifically for very small residual orbital tumors where you think that radiotherapy is an overkill, or where radiation is relatively contraindicated. Like radiation is relatively contraindicated in a patient who has already diabetic retinopathy, or is a patient who has diabetes, because those patients are likely to have accelerated diabetic retinopathy even with low grade radiation. So in such patients, or patients who don't want radiation at all for any reason, or if a patient is already one-eyed and you want to avoid any side effect of radiation, then you select out these patients for intra or perilesional rituximab. B-cell lymphoma, B-cell lymphoma. Yes. No. No. Microcystic responds poorly, macrocystic responds excellently well, but most of the tumors are a combination of both. There is one microcystic element followed by macrocystic. So it's a good idea to inject first, and then if the patient doesn't respond, then you can go for surgery. Yeah. Yes. Well, yeah, my pathologist is Dr. Mule. I totally leave it to him, whatever is appropriate. My intention is to allow him to independently do whatever he thinks is appropriate and give me the information that I need. So when do we need it? Basically, if you are operating on a patient where you don't know what the lesion is, even with the best of MRI specialist interpreting it, and clinically we are putting all our thoughts together, then we have a situation where the patient is under anesthesia and we have to take a decision whether to go ahead and completely excise it despite all the morbidity that the patient may suffer. The lesion may be infiltrating the lateral rectus or SRLPS complex, or okay, now we have reassurance that it is indeed a granulomatous lesion. Now let's not do anything further and leave it for medical treatment. Those are the precise situations where I would keep my pathologist on the standby, keep the frozen section machine on, and he has this imprint cytology and squash imprint to his advantage. Right. So we do that while the patient waits under anesthesia, and then we decide whether to completely remove it or leave it there, because then okay, it's granuloma, it is medically treatable. Sometimes we have found that even soft tissue sarcomas can present like granulomas, and yes, so patients are counseled appropriately. If it is a soft tissue sarcoma and it is, say, I know that, okay, it is a soft tissue sarcoma, now I know that, well, it can be treated by external beam radiation and perhaps chemotherapy or a combination of both, then I won't do any further intervention. But say lacrimal gland tumor, adenocarcinoma of the lacrimal gland, it's a completely surgical disease. There is absolutely no treatment choice that is available, such as chemotherapy, radiation. Some target therapeutic measures are coming up. In such a situation, what would I do? I would completely remove the tumor irrespective of what may happen to the superior rectus LPS complex. So that kind of counseling always happens before.
Thank you, sir. It's always a pleasure to listen to your talks. I would call upon next speaker, Dr. Raka Chatterjee, to talk on lid tumors, the warning signs.
Good afternoon. Thanks for the AIOC for giving me this opportunity. Now, lumps and bumps in the eyelids can present in many ways. As for example, this child presents with a lesion like this, or can an elderly gentleman is presenting with a lesion like this. Now, the approach and the prognosis of these cases will depend on the ultimate histopathological diagnosis. But we need to know certain warning signs when we should be alert enough to consider these cases to be most likely the dangerous, the malignant ones. Now the eyelid lesions are common, whereas the pattern recognition and the knowledge of common characteristics aid in the assessment of malignancy. Ulceration, irregularity, telangiectasias, Parley appearance, and loss of eyelid margin architecture. These are the 5 key features which suggest malignancy. The failure to diagnose and treat in a timely manner can lead to local tumor growth with possible direct extension to adjacent ocular surface or bit or skull bone. Late treatment may require extensive resection and reconstruction. So early detection of the eyelid cancer is the key. Now, the timeline of symptoms are like that. It can be a newly and rapidly going lesion, or it can be a long-standing lesion with a recent transformation. The different risk factors are advanced age, significant sun exposure, personal or family history of skin cancers, genetic predispositions, poor radiation therapy, or immunosuppressions like sudden genetic diseases, and also graft transplant patients, patients on immunosuppressive therapies, HIV positive patients. The red flag signs are for any eyelid tumors, the bleeding, crusting, the non-healing, or the recurrence. So as I already told that 5 points, that ulceration, irregular border, telangiectasias, Parley appearances, and loss of eyelid architectures, these are the characteristic features of malignant periocular cutaneous lesions. For malignant melanomas, these are simplified as ABCDE. These are asymmetry, border, color, diameter, and the evolution. That is how it is growing. Now the ulceration develops as the malignant cells grow haphazardly and are thought to outgrow its own blood supply. With a nodular basal cell carcinoma, the tumors are perfused peripherally, so there is central ischemia and ulceration, whereas the squamous cell carcinoma, it is at the periphery of the lesion. In melanoma, ulceration suggests a more aggressive subtype. Here you see the 2 lesions, the first one with a small regular lesion with a central deep umbilication, but this is a molluscum contagiosum lesion. This is not a malignant one, the upper left. This one. And this is a case of central black depressed area with a tumor, but this is again a benign, it was a sebaceous cyst. Now that these lesions are little suspicious, this one, this one, this one, this one, these are the ulcerated lesions with malignant histopathology. This is another case where there is extensive superficial ulcerations, and incision biopsy proved it is a case of squamous cell carcinoma of the upper eyelid. Now regarding the irregularity, because malignant tumors often have scalloped margins with asymmetric shapes, where the benign lesions such as syringomas, epidermal cysts typically have a smooth discrete border with a symmetrical shape. This irregularity occurs due to the presence of multiple cellular population growing at different rates. So as I show you, this is a lesion, margins regular. This one is also having a regular margin. This is, you know, is a clinical chalazion. This and these two looks like junctional nevi, and this is a pyogenic granuloma. These lesions do not look like malignancy. The margins are irregular. Margins are regular. Whereas these lesions here, this is a lesion with a clinical irregular margin. This is an eversion of the tarsal plate. You see how the margin looks. Here also it is an irregularity, bumpy appearance, and here it is not only irregular, the loss of eyelid margin shape is changed. The third is a telangiectasia. These are dilated irregular small blood vessels of the superficial dermis. While isolated telangiectasias are commonly seen in older sun-damaged skin, but telangiectasias overlying a raised scaly or irregular skin lesion should raise the suspicion. Here we see on top of this irregular lesion, the telangiectatic blood vessels are there. Here also, in the upper part, the lesion looks little whitish, and there is a contrast reddish blood vessels apparent. The Parley appearance is just like a pearl, a whitish and shiny appearance. It is a suspicious particularly for nodular basal cell carcinoma patients with a scallop pearly border and translucent appearance. It gives rise to a suspicion. Here, this is that I was telling you that the upper part is whitish and it looks like typical pearly papule, and there is a central ulceration. It is histopathologically, it was a case of basal cell carcinoma. And again, the loss of eyelid architecture, loss of eyelid margin architecture, meaning erosion of the mucocutaneous junctions, focal depressions or notch or other obliterations of eyelid margin landmarks, such as the meibomian gland orifices, lash line are suspicious. Now, mother-osis and necrosis also add to this. Now, this is a picture where you see how the margin irregularity, no lashes, no lid margin architecture. This was histopathologically proved to be a case of sebaceous gland carcinoma. Now, eyelid eversion is an important point. We should not forget whenever we see any lid lump or lesion, because it gives quite a good clue to what can be the clinical diagnosis and what can be our approach. Because if we forget to evert the lid and externally we see a round lesion, regular lesion, but internally the lesions, none of these lesions are quite satisfactory. These are suspicious lesions. Now, one important interesting case I'll show you is a case where the lesion looked something in eyelid, epidermoid cyst like that, but on excision it was a case of spindle cell tumor of the eyelid. Whereas this was a very thick lower lid with the mechanical ectropy, and histologically it was a case of hemangioma. Now, just to conclude, I will not discuss the theory parts. It's a case where this is clinically what is seen. All these are cases where basal cell carcinomas. Here the first one is with the rolled irregular margins with the ulcerated area. Here this is a pigmented one, and this is as I shown in the previous slide. Now, the second one is the eyelid is completely destroyed. It was histopathologically a squamous cell carcinoma. And the third one is much awaited and the commonest cancer seen in the Indian subcontinent. This is the condition of the eyelid. This is one where, and this is another type of carcinomatous erosion of the eyelid, and this is the third type. Now, all these cases, this was histologically proved to be a case of sebaceous gland carcinoma. But last but not the least, I'd like to show you a pigmented lesion in the conjunctiva extending into the eyelid. It was a case of simultaneous eyelid and conjunctival melanoma, contiguous. So to conclude, eyelid cancer is common, with sebaceous gland carcinoma being the most prevalent in Indian subcontinent, and high index of suspicion is mandated. Approximate referral in cases of suspected malignancy by general ophthalmologists to the more specialized persons. Thank you.
Thank you, Dr. Vakar. It was very useful inputs on lid tumors and lesions, because we commonly encounter them. Thank you. I would like to call upon the next speaker, Dr. Bhagavati, who will be talking on canalicular lacerations. This again a very common scenario we face, especially in multi-specialty hospitals.
Good afternoon, one and all. So after this ocular tumor session, I'll be talking with, for trauma of canalicular lacerations, I'll be giving you a few tips. I'll be dealing with the indications of canalicular repair, when to repair and how to repair. So this lacrimal drainage system forms 16% of all eyelid injury, and it mostly affects the lower canaliculus in 50 to 75% of the cases. And like any other trauma, it is more common in the children and the young adults. So when we go for managing these cases, we have to take into account not only the functional aspects, but also the cosmetic aspects. So we can classify into direct injury and indirect injury. Direct injury is caused by penetrating in sharp objects such as a knife or the spokes of bicycle or the cloth hangers, and the blouse hook injury is more common in the breastfed infants. The indirect injury is by the contusion from the punch or fall or road traffic accidents. So sometimes the injury is so occult, like this case, the 6-year-old boy, this 10-year-old girl, they had injury while playing with the fence and the spoke of the bicycle, and when you don't do probing in such cases, you are going to miss these cases, and this will heal with scarring and will lead to the epiphora. The indirect injury is usually on the lateral part away from the canaliculus, and this will stretch the lid beyond the point of the avulsion, and this will cause a tear in the canaliculus because this part lacks the tarsal plate and it is very weak. Usually the indirect injury, they are distal canalicular, they have a distal canalicular cut. Distal canalicular cut means near to the sac. The cut is near to the sac. The proximal, whereas the direct injuries are mostly the proximal injuries. This cut is towards the punctum. Now this is important to know because the distal canalicular cut injuries are more difficult to manage in terms of identification of the cut end, which is towards the sac. Now the medical management is like any other trauma, that is ensure the tetanus vaccination, anti-rabies vaccination in case of dog injuries, even antibiotic cover in case of the contaminated wounds. Now in all canalicular injuries, we have to repair with the stent so as the anatomy is restored and the eyelid physiology and the pump mechanism returns back to normal. So in all both canalicular injuries, we should do stenting. Even in the single lacerated canaliculus, there is 10% risk of epiphora. And when we repair with the stenting, it not only removes the risk of epiphora, but it also gives the good eyelid position post-operatively. So timing of intervention is no longer guided by the immediate surgical intervention or the historical recommendations of the 6 hours. And most of these cases are from the road traffic accidents. They have the associated injuries, so they cannot be taken immediately. So repair can be done within 48 to 72 hours. Even in the literature, the successful repair has been reported 5 to 7 days after the injury. So these are the different options. This one is a monocanalicular stent, and from the Orolab and the FCI, I have no financial disclosures to make. And this is a bicanalicular stents. More common is the Crawfords and the Rettlings. This is a pigtail probe. So traditionally, the pigtail probe and bicanalicular intubation was used for these canalicular lacerations, but these needs more expertise. And when you you have to pass through the normal canaliculus, so there's a risk of damaging the normal canaliculus. Now these more simpler ones are available. These you can use even for 2-cut canaliculus. You can use the individual monocanalicular stents, and these are more simpler and doesn't need much of the expertise. There's no risk of damaging the another canaliculus. Now the first step to the canalicular stenting is to identify the cut end. So this is a proximal cut end. So this is very easy to identify. You have to just pass the probe through the punctum, and you can see it coming out through this cut. So this one is a distal cut end, which is more difficult to identify. So this is more difficult to identify. Once you have the cut, this is further retracted towards the orbit, and then it is difficult to identify this cut end. So the first key step for identification of the cut end is to use the magnification. You can use either microscope or you can use the loop. I usually use the microscope and inject the very little amount of the anesthetic. And third tip is to you do the blunt exploration and keep your sharp tooth forceps only for retracting the skin. So the most important step is to, like in the literature, the different, they have given different options, like the people inject the air from the normal canaliculus, or they can inject the fluorescent stained dyes, but these has never worked in my hands. When I inject the dye from here actually, so it usually leaves through the nasolacrimal duct because there is always edema of this part. So this has been never very successful in my hand. I usually identify it from the appearance or clinically. So where you have to look, that is more important. So you have to look below and behind the caruncle. So most of the time you will be able to see this pearly white opening of the canaliculus in the pink tissue of the orbicularis. And once you feel it, it is very elastic and very thick walls. And once you see it, you are not going to forget this. Now, this is a monocanalicular stent which we use. So it is having a body which is 40 millimeter in the length, and this one is a head. So there is a bulb which will go into the ampulla of the canaliculus, and this is a collarate which will stay outside the punctum. So this is a small clip, so we have to dilate the punctum first, and then you have to pass the tip of this monocanalicular stent. You have to be perpendicular to the punctum and pass bit by bit. So once you see it exiting through the other end, then just pull it out, and then you push the bulb inside, and the collarate will remain outside. You have already identified the distal cut end, so you push it through the distal cut end. When you are in right place, it passes very smoothly. Okay, once it passes, the next step is to put the sutures. So when your cut end is towards the punctum, it is very easy to suture. That is, you have to suture it like any other marginal lid tear. But when it is towards the sac, then you have to keep in mind that you have to direct this vector of the medial canthal tendon towards the posterior lacrimal crest. So you have to pass the two double-armed suture with the cutting needle through this end, and while passing through this medial cut end, you have to swipe through the periosteum and then come out through the skin at this medial canthus and tie it over the bolster. So this is a post-op picture. You can see this collarate outside the punctum, and you can keep it for 6 weeks to 3 months, and then you can remove it under the magnification of the slit lamp or the loop. You have to just pull this collarate with the tooth forceps and pull it out. Okay, so take-home message is always suspect canalicular tear in the medial eyelid injury. Whenever possible, do canalicular tear repairs with intubation. Always and always use magnification. Thank you very much.
Thank you, Dr. Bhagwati. Actually, you made a point that you never succeeded in identifying the distal part of the canaliculus by using stain, right? But our experience is different. See, especially when they come late.
Maybe.
You won't be, I mean, it's very difficult. That the most difficult part of canalicular tear suturing, identifying the distal part. So we have used the fluorescein dye or the trypanlo, it works. So you pass through with little.
Maybe that by that time, if you're seeing late, the edema is not there. But I have always seen
I
actually
think with
one
little force, it's most of the times it comes, but it's a big help for us.
Okay.
That's what I've observed.
Okay.
Anyone from the audience can add.
Yeah. Do a blunt dissection.
But will it be there even after few days of injury? I mean, or at least correct. Especially, I'll get a call from my junior colleague. Ma'am, I'm not able to identify, then I tell this. Because I'm not there to tell her like how to identify, then I tell. Most of the time they do it.
Actually, it is too much retracted inside, and it's really difficult to see whether the saline is coming
until
out.
the edema subsides, and then I do the surgery.
Okay, fine. Thank you.
After blanching, it's okay.
Because these patients, they don't want to wait because their tear they see, so they want to get it immediately done.
Plus, in the same, they will have other injuries also.
Yes.
So in the same OT, I think the sessions we have to finish everything at the same GA or whatever.
So that position, if you just go there below the caruncle, I have usually found every time.
So
that is my experience. Yeah, it will be there.
So there's another simpler way. I have used this most of the time. So if there's no bicanalicular injury, you can just inject diluted betadine from the other canaliculus.
Diluted?
Betadine or whatever you want to use from the other canaliculus, and just you can easily identify.
If it is a proximal towards the punctum, you can identify it easily. But if it is towards the sac, it's hard to find.
So the cases that most of
proximal one is easy. You can identify.
I agree. So the cases that we get in our practice are usually not these clean cut cases. They are crush injuries. In crush injuries, however hard you may try, you cannot tell the punctal pout. Sometimes you just can't. So then it becomes a very difficult proposition, because as an oculoplasty surgeon, you feel that I should take care of epiphora as well as cosmesis, and it becomes very difficult sometimes. It's not that easy. It's not that easy. Yeah.
That will be digging and you'll be causing more and more injuries.
Beyond the punctum or a linear tear. When it is a horizontal cut, the pale pink invariably it will be there.
Challenging ones.
For
Those sharp injuries, I think they're easier than the blunt.
direct
crush
injuries are usually the towards the proximal punctum. It will be by sharp. That is easy to
Easier.
identify.
These are more of blunt crush injuries.
Towards the sac is very difficult to identify actually.
Ma'am, hi. It's a very basic question. How long do you keep the length of the mini monoca? You put the entire length or you cut
Entire. If you are in right
Invariably
place,
you need
the
to
entire thing will
like
go.
trim
it?
it.
You push the entire length?
If you are in right passage, the entire thing
pass
passes
right
inside. Thank you very much.
Thank you. End of the session. Yeah.